Have you ever felt a sensation in your legs muscles making you move them to feel some relief at night, causing you to have a sleep disruption? If this is the case, stay tuned because this is our topic today. These unpleasant sensations in your legs are called Restless Leg Syndrome or RLS. If you want to know only about the treatment because you are sure that you have this diagnosis, that this is the diagnosis, then skip this part because now I'm going to talk about briefly about how common is this problem, how to identify this problem, how to make the diagnosis, and then at the end, the treatment. But make sure that you have the correct diagnosis because if you don't have the correct diagnosis, there's no way that you can have the correct treatment. Before we start, I want to show you how to look for a topic in a specific channel. So for example, if you go to my channel here, so you need to look, for example, here, if you want to look for RLS, you type RLS, enter, and you will see the videos related with RLS here, okay? So it's basically this search icon that you see here next to community, not this one here, okay? So remember, if you want to look for a specific topic in a channel, just go to this icon here next to community, not here. Let's start by saying that Restless Leg Syndrome, or RLS, is extremely common. More common than Parkinson's disease, more common than essential tremor. Basically, you are not alone. I see these all the time in the clinic. It is the most common movement or sleep disorder. Approximately 5 to 15% of the population has this condition. Everything depends on which paper do you read, but more or less it's 5 to 15%. At least in Europe and North America, based on this study that you will see in the screen, published in 2012. By the way, this is more common in women and related with pregnancy. I will post a video about how to manage, how to treat this condition during pregnancy, which is different. Many women start having this issue or exacerbate these symptoms during pregnancy. Another important factor is age. You get older, more chances of you having this problem. Also run in the family. So that means that there is a genetic factor involved in this condition. It is more common in patients with chronic kidney disease, end-stage renal disease on hemodialysis, more common in patients with spinal cord injury, more common in patients with multiple sclerosis, and more common in patients with Parkinson's disease. We are not sure why, okay? Now, could be that this is related with iron deficiency anemia. Yes, could be. Now, in fact, approximately 30% of the patients with iron deficiency anemia, they have this problem. But I want to clarify something. There is no evidence that RLS is a neurodegenerative disease, which means that this is not a life-threatening condition. Yes, affect your life, your function when severe, but it's not going to kill you, okay? If you don't treat this condition, it might cause anxiety, irritability, it might lead to depression and memory issues because you cannot sleep well. I'm not going to talk about why this happened because I don't know, nobody knows. There are some ideas, but I don't want to speculate. The important thing now is for you to understand how you identify the symptoms, having the correct diagnosis so you can improve your quality of life. If you are sure that you have the correct diagnosis, RLS, then skip this part. However, make sure that you have the correct diagnosis because otherwise, you are not going to get better. In order to get better, you need first to have the correct diagnosis. This is the 2012 diagnostic criteria for RLS. The link of this paper, this information will be in the description of this video below, but also is here, you see here. Now, they have 5 things, 5 criteria. You need all of them, not just 1 or 2, no, all of them. The first one, you need to have this urge to move the legs, this necessity to move the legs. This is extremely important. It's not just pain. You need to have the necessity, the urge to move the legs. Also, this problem is when you are resting during inactivity, such as lying down or sitting position, okay? Number 3, partially or some lucky patients totally relieved by movements, such as walking, stretching. Number 4, this is very important because this is going to help you to differentiate between diseases or conditions. It is worse at night or evening, okay? It's not all day, unless severe for many years. We call that augmentation. We'll talk about that later. But at least initially, the symptoms has to be predominantly at night, evening, okay? Now, very important, number 5 is that you need to rule out mimic condition, things that looks like RLS, but they are not RLS, such as muscle pain, venous insufficiency, leg swelling or edema, joint pain, arthritis, legs cramps, positional discomfort, or what we call habitual foot tapping, okay, or leg rocking. So very important that you have all of them, okay, not just one, like I said before. The other important factor is these symptoms, the severity of the symptoms has to be significantly enough to affect your function, to your daily activities. To make things more simple, and actually before going that, this is the common terms that patients describe RLS. This is they describe this in many ways, including tension, discomfort. You see pulling sensation, itching. So sometimes it's very difficult to make the diagnosis when the patient describes these symptoms in many ways. So I use these 4 questions. I ask these 4 questions to make things more simple, step by step. Question number 1, and I ask the patient, it's like a check mark. Does the symptom make you want to move your legs? If the answer is yes, yes, check, go to the next question. Do they get better with movement? If the answer is yes, next question, number 3. Are the symptoms worse in the evening or at night? The answer is yes, check. So that means that you most likely have RLS. This is the diagnosis. It's a diagnosis that you can make over the phone, making sure that you rule out other conditions that look like RLS, like as I mentioned before. And then the next question is, which usually is a yes as well, is, are the symptoms affecting your life, your function? And then you treat the patient after making sure that you are not taking any medication that are causing this, and you rule out iron deficiency. Now let's talk about management, what to do. And I like to divide the treatment in steps, stages. Let me talk about stage or step 1. The first thing that you have to do is just to review, to check your medication list, because many times doctors, including myself, when we are trying to help you with a condition, we cause another problem. And that's why it's so important to check your medication list, because there are many medications that might precipitate or exacerbate RLS. So I will mention a few of them. The first group of medications are antidepressants. Specifically mirtazapine. You will see the list of medications here, mirtazapine, followed by amitriptyline or any other tricyclic antidepressant. Amitriptyline is one that we use commonly. Then duloxetine or Cymbalta is also associated, and many others antidepressants. If you ask me which antidepressant is less likely to exacerbate or to cause RLS, is bupropion. Bupropion. Well, you will see bupropion here. Now, another type of medications are any medication that block dopamine, such as antipsychotic medications or anti-nausea medication. There are some medication that we use for nausea that exacerbate this problem because of block dopamine. The list of those medications are here. Okay. Now, another thing that you should avoid or at least minimize is caffeine, coffee, caffeine, especially later during the day. Maybe in the morning is okay, but later during the day, it might exacerbate this problem. Another group of medication, this one is very important because this is a very common, because people with RLS, they tend to have issues, problems sleeping. So what they do, they go to the pharmacy over the counter and they get Benadryl. And what happened with antihistaminics, especially those that cross the blood-brain barrier, is that they exacerbate significantly the RLS symptoms. So those patients, they will notice that every time that they take medications such as Benadryl, they have this problem. Other medication that might cause this is, which is actually antihistaminic too, is hydroxyzine, medication that we use for anxiety and for allergies, Atarax, hydroxyzine. The name will be here. Now, if you ask me what medication for allergies I can use if I have RLS, Allegra. Allegra is the way to go. And the genetic name is this weird name I'm not going to pronounce. I don't know why people put these weird names to medication that we cannot even pronounce, but the name will be here. So Allegra is the medication that is less associated. Actually, it's not going to cause exacerbation of RLS. It doesn't penetrate the blood-brain barrier. Step number 2, make sure that you check iron levels, iron panel. You have to check that in the morning and fasting. Iron deficiency is very common in the setting of RLS, and it's very easy to treat. Patients actually benefit even if you have normal levels. And I say normal level because it's in question mark, because they are not normal. The problem with ferritin, which is the test that we order, very important, is that ferritin is an acute reactant, which means that it might increase when you have an inflammatory process or infection during the last 6 weeks. So, which means that this can be false normal. So help you when the ferritin is low, but it doesn't help you too much if the ferritin is normal. It is usually recommended to start iron therapy when your ferritin levels is below 75 or the ferritin saturation is below 45%. A common regimen if your iron values are abnormal based on your age is what we call, and you will see the name here, ferrous sulfate. How much? 325 milligrams. With vitamin C 100 milligrams at night with empty stomach, okay? With empty stomach. There is a problem, and is the oral iron sometimes is very difficult for our body to absorb the iron, especially if your ferritin is about 75. And actually, if your ferritin is over 75, oral iron is not going to do absolutely anything because you are not going to absorb that. Okay, so it's a waste of time, a waste of money. So those cases require IV supplementation, intravenous supplementation, infusions. I will talk about that soon. Remember, you cannot take iron supplementation without knowing your levels, your labs. Why? Because it might affect your liver, especially if you have a genetic condition that we call hemochromatosis. So, if you start iron supplementation, check your ferritin levels approximately in 3 months until your levels, every 3 months, until your levels reach around 100 or over 100. Then after passing the 100, you can stop and recheck in after 3 or 4 months again. Okay? Now, if your symptoms are severe or you cannot tolerate or iron cannot get absorbed orally, in many cases, or your ferritin levels is over 75, then you need to use intravenous IV iron infusion. A common regimen you will see here is ferric carboxymaltose. Again, a weird name, but this is medicine. 500 milligrams injection, 2 doses, 1 week apart. Okay, so there are some experts that recommend only 1 dose, 1,000, 1 time, and then recheck levels in 3 months. But I tend to recommend to divide the 1,000 by 2. So you, for example, you get your infusion, 1 dose of 500 milligrams today, and then in 1 week, another 500. This is how I do it. And then I check the ferritin levels and the saturation approximately 3 months, 12 weeks after. And I can repeat the infusion if the ferritin levels is below 300 and the saturation is below 45%. Remember, this is not magic. This is not going to work in 2 days, next day. It might actually take even 6 weeks, unless you have a severe iron deficiency anemia that those patients actually respond pretty quick in a week or so. Also, remember, I think I mentioned this before, that you can have iron deficiency without anemia, okay? So still you can treat RLS with infusion and oral iron supplementation. Step number 3, make sure that you don't have any other sleep problem, because to improve your quality of life significantly, you need to treat another type of sleep problem you might have, such as sleep apnea. And the only way to know if you really have sleep apnea is doing a sleep study. Also, things that you can do without a pill, without a surgery is or are hot baths, legs massage, and vibration devices. The FDA has given the green light to a product that is not a pill, it's not a surgery, it's actually a stimulation to a nerve that crosses the lateral aspect of the knee here. So it's a stimulation to this nerve. The nerve is the common peroneal nerve. Apparently this product approved in 2023, you can see the article is here for your reference, improve the symptoms of RLS. So it's something that I have not used yet, but my plan is to start using as long as the medical insurance cover this product. Another important factor or topic that I want to talk, because it is very common in my field, movement disorder, is what we call placebo effect. Very common in any disorder related with dopamine, which include Parkinson's disease and RLS. That means that if I give you a pill or anything that you might think is going to help you, it might actually help because somehow release dopamine. And this is what we call a placebo effect. And the problem with that is sometimes is because we have this problem, it's very difficult to find a good treatment with these conditions. And this is why it's so important that you have to be careful when how you get from where you get information and how to interpret the studies and the placebo effect in this disorder related with dopamine. I call it the mental factor. Now let's talk about what to do when all the things that we discuss are not helping you and you need medications because the symptoms are so severe and nothing is working for you. A non-pharmacological treatment is not working for you, so you need medications. So again, let's start with steps. Step one, imagine that you have intermittent symptoms. So not every day, maybe less than twice per week, something like that. So the medication that we recommend is the same medication that we use for Parkinson, carbidopa, levodopa, 25/100 milligrams. You will see here, carbidopa, levodopa. Half tablet, you can start with half tablet, and you can increase to 1 tablet, full tablet if you need to. If you are having symptoms in the middle of the night and you are waking up, then you might try the standard release or continuous release formulation, or Ritari. Ritari, you will see the name Ritari. Ritari is the, I call it the fancy carbidopa levodopa because it's very expensive, but it's a combination of 1/3 short-acting, the immediate release, and 2/3 of the standard release in a fancy capsule. The problem with levodopa and any dopaminergic agent, such as dopamine agonist that I'm going to discuss soon, is that if you take this medication, especially carbidopa levodopa, too frequently in the setting of RLS, it might cause augmentation. What is that? Augmentation is the medical term that we use when the symptoms of RLS are worse, are increased, exacerbated. So before, the symptoms used to start at 8 p.m., now start at 5 p.m., 6 p.m., 2 hours before. Now the symptoms are affecting your arms. So this is augmentation. And this is basically the intensification of the symptoms and is highly associated with levodopa or a dopamine agonist. Actually, there is some data that patients that take levodopa, daily levodopa, for this condition, 70% of them after a few years start having these issues with augmentation. Okay, so that's why I typically recommend not to use carbidopa levodopa no more than 3 times per week. I'm talking in the setting of RLS. Parkinson's disease is totally different. Okay, this is RLS. Now, another option that you can use for intermittent symptoms is the use of Tylenol, acetaminophen, with codeine. So Tylenol number 3 tend to be effective. And also the use of tramadol. You will see tramadol. Tramadol, I start with 50 milligrams, sometimes 100 milligrams. The last choice that I have for intermittent symptoms is the use of benzodiazepines. Benzodiazepines, unless you are pregnant. Because if you are pregnant, I will post another video about pregnancy and RLS. When you are pregnant, that's actually benzodiazepine, clonazepam, could be the first choice. Be aware that benzodiazepines, they have side effects that I don't like. We don't like. And I'm talking about balance issues leading to falls, problem with the memory, brain fogginess, and there is a mild, minimal risk of addiction. And I say mild, minimal risk of addiction because I'm talking about RLS. So those conditions that are related with dopamine deficiency, the risk of having addictions are very, very low, but still is a concern. Okay. Now, when I'm talking about benzodiazepine, I'm talking about, and you will see the list of medication here, clonazepam, alprazolam, and lorazepam or Ativan. Okay. Now let's talk about the steps when you have persistent symptoms, which means every day, almost every day. So the first choice usually is pregabalin. Pregabalin, you will see the name here, pregabalin. I'm talking about Lyrica. That's the commercial name, Lyrica. Or this expensive medication, which is the long-acting formulation of gabapentin. Long-acting formulation of gabapentin. The commercial name is Horizon here, at least here in US. These two medications are recommended as initial therapy before trying dopamine agonist. When I say dopamine agonist, I'm talking about Brami, Ropi, and the patch, rotigotine, okay? You will see it here. The main reason why we prefer currently in 2024 pregabalin and gabapentin, long-acting, if you can afford it, is because these two medications are not associated with the long-term side effect that you see with dopamine agonist or levodopa. I'm talking about, number one, impulse control disorder, which is highly associated with dopamine agonist, and examples of impulse control disorders are here. And the other important thing is that they are less associated with augmentation. Augmentation is the phenomenon I mentioned before when the symptoms of RLS are increased, okay? So it's less likely, or actually not associated, to have augmentation with these two medications, pregabalin and gabapentin. Now, if you ask me, what is the most common side effect of gabapentin and pregabalin is, the one that actually bother people, especially ladies, the most is weight gain. You might actually gain 10 pounds. Approximately 15% of the patient have weight gain with these two medications. Always start with a low dose. Always with a low dose. For example, I recommend to start pregabalin, Lyrica, 50 or actually 25 milligrams if you are over 65, because when you are older, the probability of having side effect, including sedation, which is another common side effect, is higher when you get older because you cannot eliminate medications as well like somebody like 20 years old. So it's different. Now, another important detail, it doesn't matter if you take the Lyrica, pregabalin, or the Horizon, or the dopamine agonist, I'm going to talk soon, is you need to take this medication 2 hours before symptoms onset. If your symptoms start at 8 p.m., take this medication at 6 p.m. Why? Because otherwise you're wasting your time, wasting your money. It's not going to help, okay? Remember, 2 hours before symptoms onset. Now, if you are suffering from obesity, or even if you have Parkinson's disease, remember I told you before that people with Parkinson's disease, they are more predisposed to have RLS. We don't know why, but there is some association. And or if you have what we call periodic legs movement during sleep, Okay, so you are sleeping and you are moving too much the legs. This is not RLS. It's associated with RLS, but this is totally different. Well, RLS, you are awake. And in PLMS, which is periodic leg movement or sleep, you are sleeping. So it's totally different. So those patients respond very nicely to dopamine agonist. Okay, so if you have Parkinson's disease, I'm assuming you have Parkinson's disease, if you have obesity, if you have the periodic leg movement during sleep, and if you don't suffer from any type of addiction or impulse control disorder, maybe dopamine agonist would be the best choice for you, the first choice for you. But like I said before, normally dopamine agonists, when I say dopamine agonists, are these medications that you see here again. I don't want you guys to get confused, are usually my second choice. And again, very important, 2 hours before symptoms onset. Now, the next step is most of the patients, when they come to our office, they already tried these 2 types of medication, the dopamine agonist and the gabapentin medication, including the Lyrica. They already tried those medications. So those patients, I try opioid narcotics, and you might be scared about that because you see in the news the high probability of addiction with opioid. And this is true, but this is a different type of patient population. This is a patient with RLS. This is not a pain patient. This is totally different. I'm talking about RLS. Those patients, the risk of addictions are extremely low. So there is not too much concern about that. So if your symptoms are severe and you tried these 2 medications before, this type of 2 medication like gabapentin and the dopamine agonist, and your life is affected, that's the way to go. You might need to try something like oxycodone and even methadone. Even doses, low dose of methadone, like 10 milligrams at night, might be a miracle for some patients. And the nice thing about this, that those patients with RLS, you keep the medications in a very low. They don't need to increase. They don't ask you to increase. That's the difference, okay? This is why don't get scared about using opioids in this setting, only in this setting. The problem with opioids is constipation, but we deal with that, okay? There are other things that we can do to improve the constipation. Make sure that you drink enough water, okay? And increase the amount of fiber if you are taking opioids. And the other thing that is not on books, but is something that you see, is that when doctors or healthcare providers see that you are on opioids, it's just a stigma. It's a misguided stigma of patients that take opioid. And again, this is wrong because these type of patients are totally different. We are not treating here pain. We are treating this abnormal sensation in your legs. We call that RLS. Another treatment that we might consider, but good luck with the medical insurance, is the use of Botox or botulinum toxin injection. We have many type of, actually 4, at least in US, and one that recently approved, long-acting, but I still cannot use that, is the use of botulinum toxin in patients with RLS. The data is mixed, so, and it's limited, but if you are lucky and you can get this approved, or the patient is willing to pay for that, afford that without the insurance, then you can try because there's some evidence behind that. Now we have more data. We need more data. The other thing that some people try and some people tell that they get better with marijuana. With medical marijuana, CBD. Again, there is not too much data about that, but it is interesting to find out if really marijuana help those patients. Before I finish, and I think I'm talking too much now, I just want you to take a look of the practice guidelines by the American Academy of Neurology. This was published in 2016, but they reviewed this in 2022. And you see that they divide these in based on the evidence, right? How much evidence we have. And we have a lot of evidence with this medication that you see here. This is the horizon, the long-acting gabapentin I mentioned to you. Level A means a good evidence, good randomized controlled trials, double-blind placebo. So very good evidence. And the pregabalin, they gave moderate evidence, level B, but I think this is gonna change. This is because there are other studies that came out after 2016 showing Lyrica pregabalin helping significantly patients. So this probably will move to level A. And remember that we talk about IV iron supplementation. This is the ferric carboxymaltase that is recommended when your serum ferritin is below 75. So you can take a look of this, but many of the things that we discussed are here. This is based on the current guidelines by the American Academy of Neurology. To summarize, the choice of medication depends on many factors, including the cost and what other condition do you have around you. In other words, how to select the patient and the appropriate medication require knowledge in many areas. Although RLS has no cure, patients get better when you use medication properly. If you like this video, don't forget to subscribe to my channel. See you soon.